And joining me today is Dr. Sarah Kremen, and we're going to talk about brain health, memory loss, and prevention. Dr. Kremen is a behavioral neurologist and director of the Neurobehavior Program at the Jona Goldrich Center for Alzheimer's and Memory Disorders at Cedar-Sinai Medical Center in Los Angeles, California. Welcome to the show, Sarah.
Thank you so much.
You also did a program with Healthy Women in June on the same topic. And Healthy Women is doing a lot to advocate for brain health in women. You want to tell us about that program in June a little bit?
Sure. The program in June, it was a 3-part series and I was the middle episode. And so that was specifically an interview with a newly diagnosed person with Alzheimer's and his wife, talking about dealing with the diagnosis and, next steps in terms of what to do once you're diagnosed. And so that's a lot of what we were talking about, was what do you do when you're diagnosed? What kinds of help should you be looking for? And what kinds of steps can you take as the person with the diagnosis or the person who's helping the person with the diagnosis moving forward?
You bring about very important issues. There's first the person who may be identifying that they're having some memory loss, or as doctors say, cognitive difficulty, and then get an evaluation. But it's a disease that affects an individual, but it also reaches many family members in terms of the caretaking and the planning. So can you tell us about what a behavioral neurologist, tell us about your work as a behavioral neurologist, because people understand that neurologists take care of brain issues, but it's a super specialized field, and I want to just talk a little bit about it.
Sure. So behavioral neurology is really understanding what part of the brain causes whatever behaviors we see. If any of you are familiar with Oliver Sacks and some of the work that he did with like books that he wrote, Musicophilia or The Man Who Mistook His Wife for a Hat, that's what I do. So behavioral neurology is really about trying to understand the brain behavior relationship. So for example, if somebody say is seeing things, why are they seeing them? It's not necessarily because they have schizophrenia. It's something going on, say, with the part of the brain that has to do with vision, but why? It could be that somebody's presenting with seizures or something like that. So, or somebody has difficulty with language. Why are they having difficulty with language? So it's a really broad field, and I love it because it covers every other subspecialty of neurology. There are doctors who take care of people with MS, with seizures, and my field kind of dips into every other one, stroke, everything else, because people will have symptoms with trouble with, their vision or their language or hearing. And I get to go and see all those people and try to help them and figure out what's the cause and how can we help them. In everyday life, it translates into seeing patients in the clinic who are concerned about memory. That's mostly what it translates to when you take it out of the academic realm and just put it into everyday life. So I see patients in the clinic who have memory concerns or other kinds of thinking concerns. And I take care of people who have diagnoses of Alzheimer's disease, dementia with Lewy bodies, frontotemporal dementia, primary progressive aphasia, these kinds of things. Yes. And also people who are, just concerned, like, is there something going on or is it normal aging?
Yeah, so that's what I wanted to point out. You pointed out some very different types of dementia or memory issues. And for the general public, people know call everything Alzheimer's disease, but everything is not.
Right.
So you want to go through those, so for our viewers to understand a little bit of the differences.
Yeah, absolutely. I think even I'll take 1 or 2 steps back from that and start there. So, we need to understand what is normal and what is dementia and what's in between. So when we have our baseline normal ability to think and normal ability to carry out all of our activities of daily living, whether that's working, driving, being able to do your bills, doing your shopping, that's what's called normal.
Right.
Then if you have a decline in your cognition or a decline, say, in your ability to remember things, your ability to speak, that will be a change in your cognitive function. But if you also have a decline in your function, like everyday living, like you're having trouble doing your bills, you're having trouble driving, you're having trouble remembering your medications, keeping your appointments, using your phone, that's functional. So a change in function and cognition, those two things makes it dementia. So normal cognition or normal function, everything normal is normal. A decline in cognition and function is dementia. There's also something in between, which maybe people have heard of, which is called mild cognitive impairment. Right. Mild cognitive impairment means that the person themselves has noticed a difference, just say in memory. Objectively, another person can see that you have problems with memory and it's been documented. So a physician has noticed, yes, on a memory test, say a screening test, there's a decline, but there's no decline in function. So mild cognitive impairment is this made up thing to just describe that you don't have normal cognition or normal and you don't have dementia. You're somewhere in between where your functioning of everyday life is still okay, but you do have a decline in cognition.
Wow.
So that's the first thing to understand, is that it's just made up to describe a condition
in between.
Right. That's all that is. So there's normal, there's mild cognitive impairment, and there's dementia. Okay.
So the mild cognitive impairment, do they later on go on? Is that a predisposition to dementia?
Right. So here's the thing about mild cognitive impairment. It depends what it's due to. So you could have, just say, a urinary tract infection that is bad enough that it makes your brain kind of addled, and you could have confusion for a little while and not be at your best. But once it goes away and you treat it, you wouldn't have mild cognitive impairment anymore, for example. Or somebody could be in the hospital with some sort of medical condition. And again, your head is attached to your body. So you could have a heart problem. It could cause, some difficulties. Say you have heart failure, then it's able to be remedied. Then you wouldn't have mild cognitive impairment anymore. Or say you have depression, that can cause memory problems.
And also some medications can do that.
Exactly. So when somebody gives you the diagnosis of mild cognitive impairment, it really doesn't tell you what it's due to. It could be due to anything. So mild cognitive impairment doesn't equal Alzheimer's disease.
Okay.
It's the fear that everybody has. There's no question that every patient walking into a doctor's office and every doctor is worried. That is the elephant in the room about mild cognitive impairment. But really, when you have mild cognitive impairment, it behooves the doctor and patient to try to figure out what it's due to before deciding that it's going to be due to something like Alzheimer's disease.
Right. So that means that you would get some laboratory tests and things like that.
That's right. So usually when somebody has mild cognitive impairment, we're going to be checking for things that are reversible because, of course, we want to fix whatever we can fix.
That's
so,
right.
A doctor will check thyroid, vitamin B12 levels, and it also depends what else is going on. I mean, if you're feeling down, then we are going to screen everybody for depression and encourage some sort of treatment, whether that's pharmacological or not. We might,
Right.
say you need therapy. Obstructive sleep apnea or other kinds of chronic sleep problems absolutely can cause mild cognitive impairment. And if those things can be remedied, then, isn't that better than, ending up with a diagnosis of Alzheimer's? So we really try to figure out what's going on and rule out everything that we think could be going on before deciding, this is something that that may have a different pathway that's harder to treat.
Right. So let's move on to some of the others when people have both the functional and cognitive impairment. Like, how do we discern, what is the cause of that?
Right.
Because to date, nobody knows people know what the brain looks like in people with Lewy body or Alzheimer's, but they don't know exactly the cause.
Right. So I think, just moving to what is dementia, right? And I have so many people who come in and say, well, does my mom have dementia or does she have Alzheimer's, right?
Right.
And so what I want to encourage people to think about is, as I said, dementia is a decline in cognition and function. That's dementia. Then we think about what is the dementia caused by. And there you have the list. So there's Alzheimer's dementia, there's Lewy body dementia, and all these other things that I've listed. And so what the doctor is doing from that point is then trying to figure out what is it due to. So we do that in several ways. One, we look at the blood tests of things, just making sure, again, there's no thyroid problem, no depression, et cetera. We do a brain scan. Neurologists prefer brain MRIs, I will say, but sometimes people will get a CT scan of their head.
Right.
But we're looking to see, has somebody had silent strokes? Or maybe they had a stroke in the past that wasn't silent, but we're trying to figure out, is the symptoms that they're having, are those symptoms able to be explained by the location in the brain where we see that injury that happened from the stroke? And we're also looking for areas of the brain that might be shrunken compared, to other areas. So maybe it's out of proportion that we would expect. And maybe that's the reason that we're seeing the symptoms.
Yeah, I mean, I think it's important for everyone to understand how we as doctors look at this to try to explain it, because a lot of times people come in and it's not like when you have pneumonia, a bacterial pneumonia, you give antibiotics, it goes away. These things it's a chronic disease, and people want to know, can it be fixed? Or others are looking on and say, it's a family member. Can we prevent this from happening to us?
Right. Exactly. Right. So, what we do when we're looking at somebody who has, some sort of cognitive concern, besides getting a really good history from them and trying to understand, how long has it been going on? Has it been progressing or not? Has it stayed the same? Is there any fluctuation in it? Have there been any, what are the features of it? Is it, you're misplacing things, you can't remember conversations, people are telling you that you're repeating the same stories all the time? Or is it other things like having difficulty keeping track of things or processing problems, that used to be simple. Now it's like trying to get through a multi-step task is hard. Are you having trouble with navigation? Are you having trouble recognizing people? All of these things that we ask tell us a little bit about the different parts of the brain and where there may be some problems, and trying to hint at giving us some clues. And then what we also do then is give some sort of cognitive testing. So if you see your primary care doctor or a general neurologist, what they'll probably do is give you some sort of screening test. It's something like called the mini mental status exam or the MOCA or the AD8. There are a bunch of screening tests that sort of touch the surface of, evaluating language, memory, attention, visual spatial skills, problem solving skills. If you come to somebody like me, we're trained to do more than that. So we will actually go in depth to all of those types of thinking and give you testing. The other way to do it is a lot of primary care doctors or general neurologists will then send somebody to the neuropsychologist. And a neuropsychologist is a trained psychologist in cognition. And they also give tests that are actually normed and validated. So they know what somebody for a particular age and education, what they should see, and they can tell if somebody's performance is below or on par for what you would expect.
Yeah, I know that people get worried every time they forget their keys and things like that. And,
yeah.
I always tell the story about when I was in college. I used to always misplace my meal ticket in a book. So I would find it the next semester, but I was always losing things.
Right. Yeah. And so, there is a difference between losing things occasionally and it not really disrupting life very much versus every day losing keys, glasses, wallet, driver's license. And it disrupting the flow of the day every day, sometimes for an hour or two. That's concerning.
And also people just losing their way.
Yes.
Their sense of direction.
Exactly. Yes, that's when it becomes concerning.
So in your program at Cedar-Sinai, you must have a team of people when a person comes in to evaluate them.
Right. Yeah, we have a multidisciplinary clinic, and we're very fortunate to be able to have that. So we have, well, I'm in the clinic, and I also have my colleague, Dr. Tan. He's a geriatrician, so he also can do the same kinds of evaluations. We overlap a little bit. He takes patients who have more complex medical issues going on, as well as memory. But then, of course, we have a social worker. We have a nurse practitioner who's geriatric and dementia trained. We have a geneticist, because occasionally we'll have a need for a geneticist. And we have a pharmacist.
That's great.
Yeah.
And you also, you encourage families to come in, right?
Absolutely. Absolutely. I have to say that one of the most important things for us in terms of getting the proper story behind each person is not just their point of view, which is absolutely important, but also information from a person who knows them well, whoever knows them well and comes to the visit. Because I can't tell you the number of times I've had people whose families are concerned about them. And I, say hello to the patient and I say, so why are you here? Well, I don't know. I'm feeling fine. Do you have a memory problem? No. And in the background, I can see the family member like they have a problem. So, sometimes people with memory problems don't have great insight, and that's not their fault. That's the brain dysfunctioning. Right. And so we need to know the history from somebody else as well to make sure that we're really not missing anything.
Yeah, it's a challenge because sometimes the family members live far away from the individual, like a parent who has dementia, and they don't realize that there's been a big change.
Right. And I've heard a lot of that actually from friends, during COVID, who are now getting to finally see their parents again after, over a year and a half of just doing Zoom. And, going into their parents' house and realizing that things don't look up to snuff, and being surprised and a little bit concerned about that.
Yeah, so this is a challenge. So now, you talked about getting MRI scans to help in figuring out which type of dementia a person has. Mm-hmm. But about the treatments, especially recently, there was a lot of controversy about a drug for Alzheimer's disease. So can you talk about the medications that are available and who they're used for, and a little bit about what the problem was with that other medication?
Sure. So first, I just want to clarify that the brain MRI can't really tell us whether somebody has dementia. But it can give us supportive information about ruling in or ruling out types of dementia. So I just want to make that clear that in order to figure out what kind of dementia somebody has, it's a combination of knowing the history that somebody gives us, the combination of the testing, the cognitive testing findings, and the brain MRI, just to be clear.
That kind of just assists in talking which type, it assists in kind of telling you what type there might be.
Right. So for example, if somebody doesn't have any evidence of a stroke, then we wouldn't say somebody had vascular dementia because it wouldn't be relevant. Right. So there are several medications that have been approved for Alzheimer's disease that we actually do use in other types of dementia. So we do use it in vascular dementia or dementia with Lewy bodies. So there are 3 that are acetylcholinesterase inhibitors. Essentially what they do is they prevent the breakdown of a very important chemical or neurotransmitter that gets transmitted between neuron to neuron. It's very important. It's called acetylcholine, and it's part of the memory pathways of the brain. So what they try to do essentially is to boost up the level of that neurochemical to stay there longer so that your brain has an opportunity to be able to use it longer. So people may have heard of Aricept or donepezil. That's one of them. There's rivastigmine, which is Exelon, and there's galantamine, which is Razidine. So those have been out for a long time. Donepezil came out in 96.
Yeah.
And then I believe rivastigmine came out in 98 and galantamine came out in 2001. So those were the first round of drugs that came out. And then we had another drug that came out in 2004. It was approved in the US, which is memantine or Namenda. And that works a different way. It blocks a different receptor, which potentially then reduces free radicals and oxidation that isn't good for the brain.
Okay.
And so oftentimes we use them together. So those have been the drugs that we've had up until June 7th of 2021. So the important thing to know about those drugs is they're all supportive, meaning that they aren't targeting the underlying cause of what's causing somebody's dementia. They're not targeting, say, the proteins that are building up and causing the neurons to die. They're not targeting that. They're just trying to support the neurons that are alive to help them to function as long as they can. So in June, the FDA approved another medication called Addicatimab or Aduhelm, which is the trade name. And the difference is that this medication is targeting an actual protein that we see that builds up with Alzheimer's disease. And that protein is called amyloid. We don't understand exactly what amyloid does. It's thought to perhaps be even protective in that perhaps it helps when your brain is trying to fight something off. Perhaps it builds up to try to help your brain. But over time, it seems that it becomes, or the thought is, it becomes harmful. And that when we're older, we're not clearing it as fast as we should. And this becomes irritable to the brain and then causes a lot of other things to happen, like inflammation and the misfolding of another protein called tau, which causes the neurons to die. So you have amyloid and tau are the two big proteins in Alzheimer's disease. So essentially what this drug does is it's a monthly infusion and it can clear amyloid from the brain. And that part is not controversial. They've actually been able to show that 3 different times, and there's no question. It absolutely does reduce the amyloid levels, especially when you can give somebody the highest dose of the drug. The reason that it's controversial is because we still don't have great evidence to show that reducing this protein amyloid corresponds with slowing down cognitive decline and functional decline. So the controversy is, even if you can pull amyloid out of the brain, there are issues with this drug. Number one, it can cause side effects. We know that people can get brain bleeding and brain swelling with this drug. So in the studies, about 35 to 40% of people did get some sort of brain swelling or brain bleeding. And we know that 3/4 of the people who had this, it was asymptomatic. They had no symptoms. So the only reason that it was caught was because as part of the clinical trials, you're getting scans, you're getting a brain scan every 12 weeks, and that's how it was caught. So there's concern that in the general community, how would you do this kind of scanning? Are physicians going to be equipped to be able to do this? Medicare doesn't really approve getting a scan every 12 weeks. So how would this be paid for? The other issue is that in order to be able to even qualify for this drug, in the study, you had to have proof of having amyloid in your brain. And that was done by getting a different kind of brain scan called a PET scan that can detect amyloid in your brain. Right. This kind of scan has been approved by FDA since 2012, but we don't use it much in clinic because it's really expensive and it's not approved. Again, it's not approved by any insurance because it's so expensive and because we didn't have a drug before, to really justify it. So the issue right now is that even if you have Alzheimer's disease and would qualify for this drug, meaning that you have mild Alzheimer's dementia or MCI, mild cognitive impairment. So say you fall into whatever severity, which is very mild disease, you still have the hurdle of how would you get the amyloid scan because it's not covered. Right. The drug is not covered. And what are you going to do about the MRI scans you might need? And the fact that it's a lot of money for potentially exposing yourself to side effects. And we're not sure even if the drug would really help. So it's really complicated. So that's that in a nutshell.
Something in general about research. You do studies to look at something improving and what we think to be as abnormal.
Yeah.
But in research, you don't look at the collateral damage that could, the collateral issues, like, oh, how will the person pay for the drug?
Right.
How will the person get the follow-up scans for the drug?
Right.
It's sort of, when you do research, you really don't think about the real life utility, even though these drugs will be used in real life.
Yeah. And I mean, I think that, let's put it this way. It's the amyloid, the whole science behind amyloid has been going on for at least 20 years or more. And what we're seeing now is the fruition of that work. And so that's why we're hearing so much about it, because there's this drug and there's actually 2 more that have been granted or going to be considered for fast track approval by other companies. So this is not going to be the only one that you're going to hear about. And the reason it's happening now is because it takes that long. It takes 20 years to go from the basic science, somebody found something in a lab, to then test it, not even in an animal, to just look at it and figure out, what's going on and how should we develop an animal model. Then they have to test it in an animal model. Then if it works, then they have to test it in healthy humans. Then if it seems like it's not too dangerous in those healthy humans, then they can figure out what dosage to use.
It's a very long process.
Exactly.
Just as an example, one of the criticisms of the vaccine is they thought it happened overnight, but actually the technology to make the vaccine has been around a while, and we lucked out. It worked for COVID.
That's right. Exactly. I mean, exactly. And actually it would have happened sooner. It's just that there wasn't a need. So, that line of research, the moment SARS went away, there was no funding for it anymore. It wasn't something that was top on our radar that we needed. So it got left. But yeah, it took at least 15 years to develop that technology. And then luckily we just happened to have it to then bring it back suddenly. But, it takes a really long time to go from a discovery in basic science and actually put it and be able to have it, as a drug that we can actually use that's licensed. It takes a really long time. So, right now we're seeing drugs for amyloid, but there are so many drugs in the pathway and in the pipeline for Alzheimer's disease. So we do have drugs that are being tested against tau. And then we have all these other drugs that are coming down the pipeline looking at, say, metabolism. So there are a bunch of drugs right now that we use in diabetes that actually we're looking at and testing for Alzheimer's disease. There are other drugs looking at inflammation. There are other drugs that are looking at, trying to stop replication of genes that may be harmful, that if you could just change it, then you wouldn't have that down the pathway. We have drugs that are looking at the gut and how the relationship between the gut, which is really the largest neuro system we have, and how the gut and the brain interact, and what can we do in the gut to change our gut health that might affect our brain health. So, amyloid is just the tip of the iceberg, and it's what we're seeing now, but it's just the fruit of labors of 20 years or so.
And speaking about when you talked about gut health in the last couple of minutes we have, is to really talk about what to preserve brain health. What are some lifestyle choices we can make?
Right. So, it's really, really important. I kind of feel like all these people come and they're expecting something, mind blowing. And then I say, well, it's sort of like what, you grew up from what your mom told you, but we have to eat well, so eating a Mediterranean diet where you don't eat much red meat, where you're eating, say, cold water fish that are high in omega-3 fatty acids, having leafy vegetables. And as a teacher of mine said, eat the colors of the rainbow. So you should have the rainbow on your plate where you have lots of fruits and vegetables of different colors that are high in antioxidants. Making sure that you're not eating that much processed food or processed sugar. That's really important. Also, super important is exercise. We can't emphasize enough how much exercising 30 minutes a day makes a huge difference. And we know this from looking at animals and in humans, that it can really slow down neurodegeneration. And of course, it's heart healthy. It also improves your mood. I mean, there's just really, exercise is so important. So we all need to find 30 minutes in our day to exercise. And it doesn't have to be 30 minutes at one time. It could be 5 minutes here, 5 minutes there. If you have a hip problem, a back problem, that's okay. Just do what you can in a certain amount of time. And then, when you're feeling good again, maybe 2 hours later, do a little more.
I was in my own work as a cardiologist. I have a patient who recently had heart disease, had to get a stent, and she liked going on her spin bike. And I said, and she goes, but I'm worried because I might be doing too much because I'm competing against all those other people who are, virtual. And I said, turn that off.
Right.
And just look at the amount of time you're exercising.
Right. Exactly. So, exercise, don't underestimate all the benefits of that. They've done work looking at how it boosts all the good chemicals in your brain and how it reduces all the bad chemicals in your brain.
And there's a suggestion that aerobic exercise can increase the chemicals to build new pathways. So
that's right.
That's really great.
Yes.
So I want to thank you, Dr. Sarah Kremen, for joining me today on Heart to Heart. This has been an important and informative discussion.
Thanks so much for inviting me. It's been a pleasure.
Thanks. Look forward to speaking with you again.
All right. Take care.
Take care. Bye.
Bye.